All right, it's 7:30. We'll go ahead and get started. Good morning, everyone. Thank you for attending our Grand Rounds lecture today. I'm pleased to introduce to you our speaker today, Dr. Carolyn Burns. Dr. Burns is Associate Clinical Professor of Medicine in the Department of Cardiology here at VCU. She's a native of Ohio and attended Youngstown State University and Northeast Ohio Medical University in a 6-year BS MD track, graduated from the University of Pittsburgh. She completed her internal medicine residency at the University of Pittsburgh and then came down to complete her cardiology fellowship here at VCU. She worked in private practice here in Richmond for 29 years, joining the faculty at VCU in November of 2023 to focus mainly on lipid management and preventive cardiology. She currently serves on the board of medicine at the Society of Virginia. We are grateful for Dr. Burns' expertise in this topic and look forward to learning from her. At the end of the lecture, we will leave some time for questions. Please submit your questions via the chat function on Zoom as they arise during the talk. We are pleased to offer both MOC and CME credits for the Grand Round Conference Series. To claim these credits for today's session, please text the code shown at the beginning at the end of the session at 804-625-4041. For questions, log on to Cloud CME account via vcucloudcme.com or contact Shannon Winston. I'll now turn it over to Dr. Burns.
Thank you for that introduction. And thank you to Dr. Hunley and the department for asking me to speak. I did want to say one thing about the legislative process. If anybody out there is interested in that, I was down at the legislature yesterday, and really the legislators look forward to hearing our voice and our perspective. And so I just wanted to give a shout out while I had some audience to offer to show you the ropes if you're interested in that kind of thing. So we'll continue. I'm talking about coronary artery calcium scoring in clinical practice today. I have nothing to disclose, and the goals of my talk include understanding the genesis of CAC scoring and how it's evolved. Also, most importantly, how we use coronary artery calcium, or CAC, in clinical decision making, and then what are some of the future refinements and perhaps future uses that we may see. So the CAC score was developed by Arthur Agatston, who's a cardiologist, and Warren Janowitz, who is a radiologist. Somehow Dr. Agatston got his name on the score rather than his mate. But when it was first developed in 1990, it was very, shall we say, poo-pooed. Many felt that it would make the public worry. It would lead to a lot of unnecessary testing and inappropriate procedures. And it took a while for it to be embraced. It was first mentioned in 2006 in the screening for heart attack and prevention education guidelines. The CAC score is derived from initially an electron beam CT single slice EKG gated acquisition, which now has switched over to mostly the multi-detector CT scans because they're most commonly used at this point. And overall, how they are derived has not changed very much in the last several years. The calcium score is determined by the sum of all the calcified coronary lesions, the total area, and the max density of each lesion. And in order for the scanner to detect the calcium, it has to have a minimum of 130 Hounsfield units, and that's the lower limit for detection. And with that, I'm going to get away from some of the nitty-gritty of how it's done and talk more about how it's being used. So in this screen, we see two Agatston scores, which come out with the same number of 200. And this is from Mike Blaha, who wanted to see if we could improve the Agatston score a few years ago. And what he was trying to show here is that on the left-hand side, the Agatston score 200 was comprised mostly of two lesions very close together, so very concentrated. Only one vessel was involved, and it was a large lesion. Whereas if you look at the lesions on the right, you can see that they're much more diffuse. The number of lesions is much greater. They're scattered and smaller. Yet these two scores are exactly the same, despite how they differ in their distribution of the CAC and the total number of lesions. And his thinking was that maybe we needed to switch to refine the Agatston score and make it a more potentially useful score for understanding. Oh, for some reason, I'm not moving. There we go. What he looked at was maybe looking at the score from a different perspective, rather than just using the heterogeneous results of the CAC, looking at whether the number of vessels on the bottom left would be a better way for us to look at the actual risk and have a better prediction of that risk. And on the right, just looking at whether it was a diffuse or concentrated type of lesion. But because all of this would add time and energy and change what is now a very simple study, really this has not taken off. He also looked at, if you just looked at CAC density versus CAC area, you can see that the hazard ratio for coronary artery disease goes up with increasing CAC area. However, the CAC density goes, as the CAC density goes down, the risk actually goes down. And this is felt to be the process of calcification, actually removing some of the lipid core and making these plaques much more stable. One of the things also that's been looked at in terms of adding risk when looking at these scores is whether you have detection of extracoronary calcification. So on the left, there is an image of extracoronary calcification, which includes the aortic valve and aortic root, as well as the mitral annular calcification, and then the thoracic aorta. And what they show on the left in this graph is that for every additional site that shows calcium, and this is usually seen in the same CAC scoring or on a regular CT. For each one that's added, it raises the risk overall. So that if you see extracoronary calcification in any of these locations, then the risk has increased in a stepwise fashion, which is important because a lot of times we see extra coronary calcification and we don't quite know what to do with that. But even a small amount in these areas raises the risk for future coronary events. So I just wanted to go over a sample report before we get too far in. I'm sure most of you have seen CAC reports and are well in tune. This was a 51-year-old female patient who underwent a coronary calcium score. You can see that in general, we report 4 main arteries, the left main, LAD, circumflex, and right coronary. There are other ways of reporting. I would say this is the most common. And as you can see, she had calcium in her left circumflex, a score of 3.8, and in her right coronary with a score of 6.8. So her total score was 10.6, which you'd think doesn't sound very high, but she's young. So if we look at the percentile, she's at the 90th percentile for her age, gender, and race ethnicity match. So all of that being said, I wanted to bring this up because we have to look at not just the absolute score, but also the percentile score. And the absolute score is felt to be a better marker for the short to intermediate time frame. Sorry, I got a frog in my throat. But maybe better for the clinical risk assessment, whereas the percentile score with comparison to the same age, sex, and ethnicity as other patients who do not have coronary disease or diabetes. And it is felt to be a better predictor of long-term risk. It also, for many, is easier to communicate a result of a test to a patient using the percentile. If you say you have a score of 10, it's hard to know what that means. But if you say that for your age, you're at the 90th percentile, I think that it's a little bit easier to understand for the patient. So this patient had a strong family history and also had elevated Lp(a), and definitely required intervention with therapy, given her numbers. So how do we determine when to use the CAC score and how to use it? This is from the 2018 practice guidelines. And what I should remind people is that when we're talking about using CAC, we're primarily talking about using CAC in patients who have no known disease and who have intermediate risk. It might be a low-risk patient that has some risk enhancers, or those with a borderline risk and intermediate risk who have enough of a risk based on their history, the risk enhancers, that you're concerned. And those are the patients that we recommend for CAC scoring. So just so you can read that a little easier, if the risk decision is uncertain, consider measuring the CAC. A CAC of 0 lowers the risk. And that is only in patients who don't have diabetes or a strong family history or have a history of current cigarette smoking. Otherwise, you can view that CAC score of 0 as being a lower risk patient. If you have a CAC of 1 to 99, it favors a statin, especially greater than 55. I would argue, especially in younger people too, if they have a CAC elevated at a younger age, they should be treated. And in those with CAC greater than 100 and or above the 75th percentile, we should initiate statin therapy. And for those patients, try to get them down to a LDL less than 70. So this graph is from the 2022 update, and it uses the same decision making in terms of when to use CAC. And I just wanted to put in here about the risk enhancers, specifically high CRP, Lp(a), positivity, increased ApoB, and elevated triglycerides, in addition to metabolic syndrome and the other ones we're typically looking at. The ones at the bottom are ones we pay specific attention to, and making our decision about what category we feel the patient is in to start with, and whether or not a CAC would help determine a need for therapy. So in our practice guidelines, the 2019 guidelines, or 2020 actually, were for primary prevention, and the level was used to inform shared decision-making after the risk assessment. In 2022, the wording changed slightly. The CAC measurement in adults without disease for patient hesitancy. So it is true sometimes that we see patients who say, well, I don't want to take a statin. I hear they're evil, and I don't think I need it. Or if we ourselves are uncertain about whether a patient would benefit from being on statin therapy, CAC measurement is definitely something that should be considered. And this is just a summary of the major global guidelines for CAC. And in general, there is a lot of commonality between different countries, including the age at which we typically start to measure CAC, greater than 40, those with intermediate risk, and those who are asymptomatic population. The common threshold, a CAC of 0, downgrades your risk, whereas a CAC greater than 100 definitely increases risk. There's some non-agreement about whether or not a CAC score can help inform when to start an aspirin in a patient, or for antihypertensive medication. And down in the lower right corner, I put a bold arrow to point to the U.S. Preventative Services Task Force, which reported that there is insufficient evidence to use the addition of CAC for a risk assessment in asymptomatic adults. And I think this has done a great disservice to payers looking at CAC as something that is necessary and widely used and very helpful for patients, because they often look at what the U.S. Preventative Services Task Force says should be included in our armamentarium, and so their refusal to recognize CAC as something that is a good risk assessor, I think is partly why we don't have coverage for CAC scoring. And I'll mention that again in a few minutes. This just goes to show you there's a lot of similarity around the world in how CAC is used, and a lot of different societies, including the SCCT and the NLA, who have weighed in on using CAC and how to use it. So let's just talk about CAC scoring. We know that it's been incorporated into the guidelines, including the ACC/AHA guidelines we've talked about, the Society of Cardiovascular Computed Tomography guidelines, and even the Princeton consensus guidelines for the workup of men presenting with erectile dysfunction. And so there's a lot of additional angles for using CAC that weren't, I think, appreciated when it first was developed, how useful it may be. At this time, I'm just going to introduce a case. This is a 67-year-old African-American female who I saw recently. She has hypertension and hyperlipidemia. She has been on statins in the past, but is completely intolerant. She's tried over 4 different statins. She is taking ezetimibe, but her LDL is greater than 200. And she has a family history with her mother having had a stroke in her 60s. Her father and her brother also had coronary disease bypass surgery when they were in their 60s. So her pooled cohort 10-year risk gives her 8.3% over the next 10 years. We did the MESA calculation. If we included CAC in the MESA calculation, her risk actually went down to 2.6. And part of that is knowing that she has a CAC of 0. The MESA without CAC scoring was 5.6% over the next 10 years. Her blood pressure is well controlled. She does have an elevated Lp(a), and her CAC score just a little over a year ago was 0. So this is the kind of patient where you're wondering, should we push treatment because her numbers are crazy and she has family history, etc. Or does her CAC of 0 get her out of jail and allow her to stay off any additional lipid-lowering therapy? So this is the kind of question that we have to answer. I can tell you that she also had a CTA when she had her CAC score. And her CTA at that point demonstrated that she had no significant coronary disease detectable. And so she was left off therapy or just left on ezetimibe. And the plan is for her to get a carotid Doppler since her mother had a history of stroke, and for us to repeat her CAC score in a few years just to monitor her, but not to increase her therapy at this point. So just wanted to share this about how having that CAC score and the CT, I guess, as well, allowed us to downgrade her risk. So we also have the SCCT and the Society of Thoracic Radiology, who has given a Class 1 recommendation for the routine assessment of CAC on ungated chest CT scans. For example, the lung cancer screening annual visits. There are a lot of CT scans done, and the information that we can glean out of a non-gated CT scan is actually quite good, semi-quantitative at this point. They developed a reporting system that would allow non-gated CT scans to report out. It's called the CAC Data and Reporting System, or CAC DRS. And with this semi-standard, semi-quantitative look at whether there's no CAC, a mild CAC would be less than 1/3 of the artery affected, moderate 1/3 to 2/3 of the artery affected, or severe 2/3 or greater than 2/3 of the artery affected. So the sum of the score for each of the coronaries is done for total with 3 segments in each coronary. That equals a total of 12 possible points. And this is one of these readings that my patient had. You can see in the coronary arteries, the left main had nothing. The LAD had a score of 1. The circumflex 1, and the right coronary 1. So the total coronary artery calcium score was a 3 out of 12, which would mean lower score. And the other finding in this patient was that they had significant plaque deposition in the thoracic aorta, which we know from previous discussion that the presence of extra coronary calcification increases the risk. And they also describe her descending thoracic aorta and proximal abdominal aorta as being near porcelain. So this is something that would really raise her risk above just what her CAC readings would show. And this is very helpful. This patient doesn't need a CAC score. She had a CAC score from her CT scan. And I think there's plenty of information for us to know how to move forward with this kind of patient. You will see CAC scores or CT scans where they mention there's a scattering of calcium, or you may see where they don't mention the coronary calcification at all. It's still being done that way, but in general, and especially here at VCU, they're very good about giving us that data so that we don't need to do an extra procedure to figure out a CAC score. So I just wanted to show this readout of a CAC score that was done elsewhere. A couple of things. They added an extra coronary artery into their descriptor, and they also used a little bit different levels of calcium scoring interpretation. So it's not homogeneous how CAC scores are used. I would say that for the most part, people are using the score that we've been talking about, looking at 4 arteries and summing them up. You can see some that are look different, and you just have to read down to the percentile rank and get a better understanding about how that differs from what you're used to seeing. So here are the CAC levels that we currently use. we consider a low risk being 0. And therefore, unless they have risk enhancing factors and or family history or elevated profile on their labs, they may need no treatment whatsoever. For those with mild disease, which is a 1 to 99 or less than the 75th percentile, we treat to achieve an LDL less than 100. For moderate disease with CAG score of 100 to 299 or greater than the 75th percentile, we treat to achieve an LDL less than 70. For severe, greater than 300, this is considered equivalent to a prior MI, and the treatment goal is less than 55. And a very extreme risk, greater than 1,000, it's equivalent to having multiple prior cardiac events, with the suggestion that LDL be less than 55 or perhaps even less than 40. One thing to note is that if you have moderate risk, you have 10 times the risk of having an ASCVD event as compared to the CAC of 0. So a lot of times when we've diagnosed people with having coronary calcification, the next question is, do we need to do additional testing? And this slide was a review of several different studies that sort of looked at the CAC level and whether or not there was a significant finding of significant coronary disease. And what they found was that unless your CAC score was 400 or greater, the benefit of doing a study in this is an asymptomatic person, mind you, who just has a elevated CAC score. It is not recommended for those with a CAC score less than 100 or 100 to 400. But greater than that, you can see the incidence of having abnormal SPECT goes up significantly above 400. And so that is one way to look at it. It's always a difficult decision to make, especially when you're seeing perhaps a younger person who's very active and they want to know, can I continue to run marathons or something like that? So it has to be something that's thought about, because we all know that we get little abnormalities often on SPEC scores, and then we have to figure out what to do with those. So this was just one relatively large study looking at how things point to doing some sort of additional testing if the CAC score is greater than 400. I also wanted to bring up about the use of CAC versus the other risk factors that we've been using for years, how they compare. And it has been noted by many that the CAC score seems to outperform just about every other risk stratifier that we've used in the past. And so this is one way of looking at the area under the curve, false positive rate on the bottom, true positive rate on the left side. And as you can see, CAC score definitely has the highest area under the curve, beating out IMT Framingham risk score, high CRP, LDL, HDL, smoking, hypertension, and even diabetes. I think this is just one of many studies that has shown that CAC really is a stratifier that we can depend on. This is another group's calculation. It includes the female sex and smoking, and shows that looking at how the calcium score matches the relative risk of all of these other risk factors we've been following for years, I think really lets you know how beneficial having a CAC score can be. There's also been a lot of talk about CAC score progression, and there are some studies that have shown following diabetics with serial CAC scores helps you determine when patients are not well treated. I would say in general, in normal everyday practice, we don't typically repeat CAC scores over and over and over. And this is one study that demonstrated in patients with all levels of CAC score, if there is a less than 15% change year over year in the CAC score, those patients tend to be free of coronary events. However, if you have a greater than 15% change in your CAC score year over year, you have a significant risk of having an event. And that doesn't even depend on what your CAC score was at baseline. You can see a CAC of 1,000 is in the pink color, and on the left, where there was apparent stabilization of plaque, they had the same sort of risk as the CAC of 30 to 100. So this really goes to show you that if we can get patients to a place where they've stabilized their plaque, then their risk is much better overall than those who continue to increase CAC year after year despite therapy. And perhaps it's because they don't have adequate therapy that this change happens as well. It's one thing to think about. So this is looking at an additional study that was done to determine whether, if you reported to the patient and the ordering physician on the coronary calcium in a non-gated CT scan, whether that had a benefit for the patient in terms of getting them on therapy. So out of 2,100 patients, 424 had calcium, and then they adjudicated out those who were already on statin therapy. So they had 178, and they randomized those to people who had a report made to the doctor and to the patient about the presence of coronary calcification versus those who did not have any report. And they found that at the end of 6 months, 51% of the patients who had been informed and their doctors had been informed were on statins versus just 69% of those who were on who were not informed. They also mentioned they had more coronary disease testing after the notification as well. But I think what is important about this study is that we do all these CT scans. Um, a lot of times they report about the extra findings, but many times that's hidden because the person who ordered the test may not be looking for coronary calcification. They're looking for whether the nodules have gotten bigger or whatever reason they ordered the test. And therefore, it can be missed if nobody's looking at the full report or if it's not reported out. I think what this study tells us is that we need more active reporting if possible. I know at VCU, if somebody has a significant calcium score or other finding, they send me a notification, just letting you know we found this. So I think it's very
Okay.
helpful to have
He's
that.
the one that we.
And I also
Okay.
think that we need to look at the patient's chart when we're taking care of them and see if there's information in there that hasn't been looked at or acted upon. So the CT scans are very helpful, but somebody has to look at them. Just a few weeks ago, I had a patient who came in who's been getting CT scans for a decade at least. And um, I asked her if she was there about her coronary calcification because I had no information why she was referred. And she had no idea she had any coronary calcification. No one had ever brought it up to her. So we have lots of work to do to stay on top of this now that we have a good sense of what to do with the information. So the Right Care Initiative, which is a group of people looking to improve the risk of having coronary disease and events, has been working on this guideline for coronary calcium, sort of a staging, just like we would do for heart failure. This would be a coronary calcium staging. And it's interesting that coronary calcium is actually used in the staging of the cardiovascular kidney metabolic syndrome. So this scoring system was developed and put out about 6 to 8 months ago. I don't know that it will be adopted, but maybe slowly over time we will see it adopted by different societies and therefore come to make it a little more uniform scoring system. That this is what it looks like. Using a staging system, the score of 0 means a CAC of 0. And in that case, promoting good health, healthy eating, life's essential aids, basically, would be recommended. And then in level 1, the CAC score of 1 to 99 and less than the 75th percentile, promote life's essential aids and consider whether or not a statin is needed, and work to achieve a goal less than 100. And much of these are repeat of what we've already been talking about. In particular, in stage 2, if you have greater than the 75th percentile, then again, we need to make sure that the patient is aware that they have moderate atherosclerotic burden. Statin therapy should definitely be initiated with a goal less than 70, and considering low dose aspirin. CAC score 30 to 999 is a very high risk. Again, we talked about that. We do all of the interventions and try to achieve a goal of LDL less than 55, and low dose aspirin would definitely be should be considered. And then the highest rank is the CAC score greater than 1,000, which we talked about has extensive atherosclerotic burden and extreme risk. And I suggest considering emerging therapies such as colchicine if the patient has considerable risk, and to potentially decrease that risk if they're well controlled on their stats, etc. So this is something that you may see. It will help solidify how things are determined, how they are reported out, and I think it would be a grand idea to have everybody on the same page. And you'll probably be hearing more about that in the future. So I just wanted to talk about the cost of coronary calcium, because as I mentioned earlier, it is not covered by insurance, except in Texas and New Mexico. A few of the plans will cover a CAC score. You have to be over 55, I believe, at least, to get it covered. In the greater Richmond area, the cost is about $100. That's what it is at VCU. In larger markets where there's more competition, it's sometimes much cheaper, but it can also be much higher if you're in an affluent area. So it's all over the place. And as I mentioned, it has not been, or it has proposed to not have been written into the guidelines, which is totally false. But I think one of the big stumbling blocks is the U.S. Preventative Services Task Force, who has not endorsed that, saying there's insufficient evidence that it adds to our treatment of our patients. But what we do know is that even $100 is a barrier for some people. And I think this is something that maybe we could try to propose to our legislature and see if we can get some movement. I know that's how New Mexico was able to get coverage, was two physicians worked on getting that done. So in the last few minutes, I just wanted to share some unique uses of CAC. In the SELECT trial, where we looked at patients with established CVD, to see the reduction in MACE. We have now expanded that by applying it to the MESA cohort, and trying to determine whether coronary artery calcium could help us better allocate who should get semaglutide, since it is difficult to get. And so this was an interesting study. The patients in MESA had to meet the BMI greater than 27, and then they had a CAC score, and they looked at how the relationship of the CAC score to MACE, heart failure, kidney disease, and all-cause mortality. So they compared a CAC of 0 to a CAC of greater than 300, and they looked at the number needed to treat. For MACE, the number needed to treat for a CAC of 0 was 653 versus 79 for a CAC greater than 300. Heart failure was even a greater difference, 1,094 versus 144. And chronic kidney disease, 1,044 versus 144. All-cause mortality, CAC of 0, number needed to treat was 408 versus 98. So this was felt to be a potential way to prioritize who would benefit the most from this therapy that is still difficult for many to get. And lo and behold, this has been used to look for the benefit statins, aspirin, icosapent PCSK9 inhibitors, and even stricter blood pressure control. So they're looking in very unique ways at how to figure out who best would benefit from these things in the setting of variable CAC scores. And lastly, I came upon this study. It's from the atherosclerosis risk in the communities, or ERIC cohort. And they were trying to see if coronary artery calcium could somehow help us understand whether patients are aging well or not. So they looked at the association of CAC with aging. In this group, 10% of the patients had no CAC. And these are all mean age of 80 in this category as well. So then a CAC of 1 to less than 1,000, and then a CAC greater than 1,000, which had 19% of the cohort in that group. So the majority were in the middle group. This was more female than male, and mostly white grouping. And they looked at these 7 domains of aging listed here, including cognitive function, hearing, ABI, etc., grip strength at the bottom. And what they found was that those with a CAC of 0 had a lower mean composite aging score. And those with a CAC greater than 1,000 had a higher score. So I'm not quite sure what they would do with this other than trying to improve the people who had the lower scores. But I just thought it was an interesting way for them to use CAC scoring to try to determine how people are aging. And I think we're going to see more and more use of CAC used in very different ways in the future as well. So I'm going to stop there. This is a shout out to the folks who work in this space. And if you have anybody you feel would benefit from seeing somebody in the lipid / prevention clinic, we'd be happy to see them. And with that, I'll take any questions.
Thank you so much, Dr. Burns. That was a great presentation. Certainly learned a lot from that. The one question I had was, more so about the case that you presented with the lady with the family history of cardiovascular disease, and her LDL was above 200, and her calcium
Mhm.
was negligible or zero. Those kind of cases always perplex me, because at one side I understand that they don't have a high calcium score, but at the same time, just having a LDL of that high, doesn't that put them at a higher risk of just having a ACS event? And how do you tailor therapy to that?
Yeah, I mean, anybody who saw a LDL greater than 200 would say, oh, we're talking about FH, we're talking about a very high risk person. Um, However, we do know that people with very elevated numbers often, not often, sometimes do not go on to have any coronary events. Those people exist. And this woman was already 67 and she had a CAC score of 0. Um, and I think knowing that she had a CAC score of 0 and all of her risk factors other than her LDL were very well controlled, we were willing to say, yeah, we'll just watch you. She didn't want to take any type of injectable medication, which would have been what we would have suggested if we thought her risk was elevated. Um, but it makes you very uncomfortable doing that. But she is very in tune and will, you know, show up for her follow-ups and let us know if anything changes. So I think the CAC of 0 and also knowing that she didn't have any significant coronary disease detectable on her CT scan gives you a little plus. Uh, Makes you feel a little better about leaving her off of any other medication.
Absolutely.
Um,
One of the other interesting slides that you showed was like where if the score is stable, it just tells you that the plaque is now not a vulnerable plaque anymore. It's just the event significantly decreased. That was certainly a good thing to learn. Dr. Hundley poses a question here. He says, do you have situations where there are very low CAC scores or CAC score of 0, but there is evidence of soft plaque on the CTA? How do you manage those cases?
yeah, that is the one downfall of depending upon the CAC score entirely. And if we got a CAC score and didn't order a CT, we wouldn't know whether they had soft plaque or not. Um, but I think that if you have that uh, knowledge, you have to act on it because we know soft plaque is what is much more likely to cause problems. So I would say that should be treated.
Carolyn, wonderful talk. Can you
Thank you,
address
Ho.
the, and you look wonderful as well. Can you address, sometimes you get patients who see their primary care physicians, they're on statins for 10 years, they're 55, they're runners, and they have a calcium score of like 800 on these scans from primary care doctors. And we know that statins increase external calcium and, mechanism for stability, et cetera. But do these studies exclude patients on statins or red rice yeast extract? Is there, the people on statin therapy who come to you with these high scores, what do you do with them?
Right. So we do know that over time on statins, you can have increase in calcification, but generally you're not going to see a score of 800 coming just from being on a statin. Um, so I I I like to review what was happening at the time they started the statin. Did they have a CAC score then? But a CAC score, in the 800 range is definitely, especially in somebody who's younger. You mentioned running. I know not all runners are young, but um, I think that you have to assume that they have real plaque and do your best to figure out whether there's, genetics involved or something else. But I would take that seriously and not just write it off as being from somebody being on a statin for a long time.
And just as a follow-up, what do you say to these Joe Rogan followers who come to you with the recent, you know, stuff on statins? Do you have any anecdotes or antidotes against the Joe Rogan podcasters?
Um, I haven't seen too many of those, but I think I just try to stick to the science and um, hope that you can get through. Some of them don't want to hear anything different, though.
Thank you so much again. This has been great, very educational. Really appreciate all the knowledge that you have bestowed on us today. Again, if anyone has any further questions, please feel free to reach out to me or to Shannon, and we'll be happy to redirect those questions to Dr. Burns. And thank you so much for attending the Grand Rounds today.